So before we start talking about the details of central cord syndrome, we need to first talk about what structure is affected by this problem, and that is the spinal cord, as the name suggests. So let's start with a diagram that kind of lays the groundwork for an understanding of what this structure is, as well as what parts inside the spinal cord are affected by this problem. To understand central cord syndrome, we first need to understand the structure it affects, the spinal cord. So let's take a look at this image here. What you see on the left is the spinal column in the human body, made up of blocks of bone which protect the spinal cord. And this column can be divided into different areas: the cervical spine, which is the neck region, the middle area, thoracic spine, lower low back area, lumbar spine, and then finally the tailbone or the sacrum. So in the cervical spine, which is really where central cord syndrome occurs, we've got 7 bones protecting the spinal cord. These are all stacked up on top of one another, and the bundle of nerve fibers running through the back or middle section of this spinal column is the spinal cord, which is shown much better on this picture in the upper right. So here you can see the bones of the spinal column. In real life, they're actually a little wider than this picture shows. But then inside this canal formed by this bone, you have the spinal cord. And if you take a look at the spinal cord itself, it's got kind of these dark and light colored sections. This butterfly area is the gray matter, where the nerve cell bodies are located. And then surrounding the outside of this darker area is the white matter tracts, which are where the nerve fibers run up and down, where they come from the brain down into the spinal canal, or they come from the body up, going up the spinal canal. So let's turn this cross-section area of the spine so that it's facing us. And what we see here is this picture down on the right, bottom right. And this is basically looking inside the spinal cord. And this is what explains why and how central cord syndrome occurs. If we zoom in on this cross-section area, we can see this little black outlined circle going down the center, and that is called the central spinal canal. Spinal fluid usually runs up and down this. This is a normal finding, and because this is called the central canal, and the injury in central cord syndrome occurs around this area, that's where the name central cord syndrome occurs. So this butterfly-shaped structure is the gray matter, the nerve cell bodies that we talked about. So in the cervical spinal cord, you're going to have nerve cells that go out to the arms and come up from the arms. The cell bodies of those nerve cells are going to live in these areas in the cervical spinal cord. Outside of this gray matter area, you see these areas here with different colors in them. And this is what's important in central cord syndrome. If you notice, the green area are the arm fibers, and the red area is the leg fibers. And if you look in these striped areas, the arm fibers are closest to this central canal. So when you get an injury affecting the center part of the spinal cord, the arm symptoms or abnormalities are going to be much greater than the leg, because the arm symptom or our arm fibers are closer to the center of the canal. In addition, as I said before, the cell bodies of the nerves that are going to and from the arms are located in this central area in the neck section. So if you have an injury to the cervical spinal cord in this central area, it's going to affect the arms more than the legs, which is why we see what we see in central cord syndrome, which we'll talk about in a little bit. So this picture here really helps explain why symptoms are in the pattern that we see. Although younger people can get central cord syndrome due to trauma, most likely we see this in older people because they are more likely to have that buildup of arthritis, such as bone spurs, thickened ligaments, disc bulges, that narrow the space for this spinal cord, which doesn't give it a lot of room if it bounces back and forth in a trauma. In a younger person, they tend not to have bone spurs or thickened ligaments or disc herniations, and therefore when this spinal cord kind of bounces back and forth in a trauma, it has plenty of room to do that in a younger person compared to an older person. and that is why central cord syndrome mostly occurs in older people with arthritis in their neck. So now that we have a pretty good understanding of the anatomy of the cervical or neck region of the spinal cord, let's talk about the syndrome of central cord syndrome and why that happens. So as the name suggests, as we mentioned, the injury to the spinal cord is around the central area of the cervical spinal cord. And central cord syndrome is the most common, what's called incomplete injury of the spinal cord. Incomplete injury means that the fibers or nerves in the spinal cord are not completely damaged or irreversibly damaged. A complete injury would be where those nerves or the spinal cord is severely injured to the point where irreversible damage has occurred, or the spinal cord has been completely severed, for example. In an incomplete injury, and by the way, central cord syndrome makes up about 50% of incomplete spinal cord injuries. In an incomplete injury, there's hope. There's a chance that the nerves and their function will recover. And that is actually what occurs most of the time in a central cord syndrome patient. So how does this happen? Well, the most common reason for a central cord injury is a trauma that occurs to the spinal cord in the setting of narrowing of the spinal cord. Now, a narrowing of the spinal canal area most commonly occurs due to a buildup of arthritis. A buildup of arthritis can include things like growth of bone spurs or thickening of ligaments. Let's take a look at some pictures of what that looks like, both on diagrams and MRIs or CAT scans, to show examples of narrowing of the spinal cord, which can lead narrowing of the spinal canal, which can lead to an increased risk of the spinal cord being injured in a trauma. And for central cord syndrome, the most common trauma to occur is a hyperextension injury of the neck. And that basically means anything where the neck can be thrown back suddenly like this. So that can occur in a fall where your chin or forehead strikes a hard surface. It can occur in a car accident where the head is whiplashed forward and backward. Anything where the head is suddenly thrown back or forcefully impacted from the front can lead to an extension movement of the neck, where the spinal cord basically is pushed up against the front of the spinal canal. And if the spinal canal has bone spurs in the front and the spinal cord pushes up against that, you can get a sudden injury or bruising impact injury to the front center part of the spinal cord. So as I said, let's take a look at some pictures and what that looks like. So now that we understand spinal cord anatomy and how it relates to central cord syndrome, let's take a look at some more pictures to describe that. So here we have again the cross-section of the spinal cord, and in this picture you can see this sort of shaded gray bluish area is the area of injury with a central cord syndrome. You can see it's affecting all of the gray matter in the center circle here. This will have the nerve cell bodies for the arms, and it also affects the tract leading from the brain going down to the arms here. More extensive injury will then creep lower down the legs. You're also going to have effects on pain and temperature. You're going to have effects on sensation of touch and vibration. So again, all affecting arms more than legs. And you can see the picture on the left, this bluish distribution corresponds to symptoms from central cord syndrome. You're also going to get symptoms in the legs usually, but not as bad as the arms. So over here we've got some CAT scans of the cervical spine. The picture on the left is looking from the side. You can see the back of the skull up here on the left-sided picture. You can see the bones of the neck. You can see the arthritic changes in between the bones, the spaces in between the bones of the discs. You can see these are pretty worn out, but more importantly, you can see these bird's beak looking structures in the back of the vertebral bodies, and these are bone spurs that have grown over many years because these shock absorbers are not working properly. If the patient falls forward and hits their head, or gets in a car accident or falls off a ladder, etc., and the head snaps back, you can imagine the spinal cord pushing against these bone spurs, causing injury to the central part of the spinal cord. This picture on the right is sort of a looking down the barrel of the gun view of the spinal canal. This circle in the middle is where the spinal cord lives, and again you can see this little bone spur here sticking out of the bone that could push on the spinal cord if the patient has trauma. And the spinal cord lives in this space in the middle where my arrow is making a little circle here. So again, these are CAT scans. CAT scans are very good at looking at the bones, and you can really see these osteophytes or bone spurs on the vertebral bodies that can lead to central cord syndrome. And finally here we're going to look at some MRIs, which are not as good at looking at the bones as a CAT scan, but it is very good at looking at the spinal cord. So this picture on the left is similar to that first CAT scan image we looked at. This is a side view of the neck. You can see the bottom of the brain up here at the top and the spinal cord running down. The white colored material on the MRI is spinal fluid. So the spinal cord is kind of floating or being bathed in this spinal fluid. And then right here between the number 3 bone and the number 4 bone, you see this piece of disc sticking out. And you can actually see bruising in the spinal cord, which is this white discoloration. You can see some ligaments thickened back here. So from trauma, the spinal cord got dinged against that little piece of disc and now has injury in the central part of the cord. If we take a look at this middle picture here, you can see this is probably an older person, at least, in their 60s or later, with lots of bone spurs and discs sticking out of the disc spaces and from the edges of the bones, narrowing the spinal canal, many areas where the spinal cord could get pinched in a trauma, causing bruising of the central part of the spinal canal. This picture up on the upper right is a cross-section of the spinal canal with the spinal cord in it, and this is an image of what a normal-looking spinal canal would look like. The white color around the spinal canal is the spinal fluid. The dark circle in the middle is the spinal cord itself. It's kind of a nice rounded shape. You can actually see the nerve fibers coming off of the spinal cord going into the neural foramen, which are these holes which allow the nerves to go out of. The disc or vertebral body would be right here, and we don't see any bone spurs or discs pooching out into the spinal canal. If we compare that to the picture on the bottom right, this would be an example of what the spinal canal would look like in a cross-section of one of these pictures on the left, if we did a cross-section through one of these areas. Here we can see the spinal cord relatively pancaked, and all this sort of black and grayish stuff sticking out here is likely a bone spur coming off of the vertebral body here. And the spinal cord is flattened, and you can see this white discoloration or bruising inside the spinal cord in the center area. And again, this is an example of trauma to the spinal cord from something in the front of it during some kind of trauma. So now that we understand the anatomy of the spinal cord as it relates to central cord syndrome, let's now get into more about the symptoms. We already mentioned the arms are usually worse than the legs, but let's divide up these symptoms into sort of 4 core symptom areas. One would be motor control, which means strength or movement. The other would be sensation. That includes vibration, pain and temperature, proprioception, which is the ability to know where your limbs are in 3-dimensional space, bowel or bladder problems, and then finally other categories. So let's talk about those in a little more detail. So when we're talking about motor control or strength, we're talking about the arms worse than the legs, as we've mentioned multiple times. And then within the arms, the hands and the fingers are worse than the upper arms. This usually includes hand clumsiness, difficulty with fine motor skills, difficulty therefore with gripping, writing, buttoning buttons, things like that. The leg weakness, as we said, is milder than the arm or hand weakness. Some patients can walk but can't use their hands. So there can be a big discrepancy of arm versus leg symptoms. As far as sensory problems are concerned, that will usually involve pain, temperature, and touch or vibration. Those will again be worse in the hands than the upper arms, and then worse in the arms than in the legs. This will be altered sensations where touch and pinprick or temperature don't feel normal. Some patients can feel like a band of tightness around their body. If they do feel that, it's usually in the upper thoracic or chest area. The sensory loss can be patchy. It can be worse on one side than the other. And then lastly, with regards to sensation, patients can get problems with pain. And this can also often be neuropathic pain, which has a burning quality to it. And that is from direct injury to the nerves themselves. That will often be worse in the upper arms than in the hands. That also can occur in a delayed fashion. That neuropathic burning pain can occur in the second or third week when it wasn't there in the first or second week. And then when it comes to bowel and bladder symptoms, usually bladder symptoms are more common than bowel symptoms. And these bladder symptoms are usually shown up as urinary retention, meaning the patient can't pee. The reason for this is the nerves that control the sphincters or muscle tightening parts around the bladder can be injured in central cord syndrome. So when patients can't pee, they often may need a catheter in their bladder, and don't be surprised if that has to stay in for a week or two. Usually they will do a trial of void, which means the catheter will come out and they'll see if the patient can pee. If they can't, they'll put the catheter back in. The bladder symptoms can take longer to improve than the arm symptoms. Bowel dysfunction, as I mentioned, is much less common but could be present. With regard to other symptoms that occur, that can include sexual dysfunction in men. That means impotence, spasticity, which is stiffening or spasms of the muscles. This can occur slowly over time, over the first few weeks. Keep that in mind. Fatigue or tiredness can occur during the initial stages of this injury. A lot of that has to do with the emotional aspect of this injury, not sleeping well. And then finally, the emotional, psychological, cognitive effects, which occur not only with the patient, but with caregivers and family members. So that's the fourth category of kind of other corollary symptoms associated with central cord syndrome. One thing to keep in mind, or it's important to understand, is that no two patients of central cord syndrome are really alike. Many factors determine how bad it is when a patient gets a central cord syndrome. That includes things like the extent of the injury, the patient's age, other medical comorbidities the patient might have, pre-existing health things, that kind of thing. All of these things can affect how bad the symptoms are upon presentation, as well as how much the patient improves. Also keep in mind that because no two cases are alike, some patients with central cord syndrome can walk into the ER on their own with mild hand weakness and tingling. Other patients with relatively minor head trauma could have a severe enough central cord syndrome where they can't walk and they can't pee and need a catheter immediately. So again, just keep in mind that no two cases are the same, and a lot of it depends on what kind of anatomy you're dealing with in the spinal canal and what kind of injury you've had. So how do we diagnose central cord syndrome when a patient shows up in the ER or a doctor's office? Well, a crucial part is the history. If the patient is on the older side and they describe some kind of injury or trauma where they hit their head and their neck went backward, and they're coming in with complaints of arm and hand symptoms, you initially or immediately should think of central cord syndrome. When the patient lands in the ER and they've had some kind of trauma like this, they're usually going to immediately get a CAT scan of the spine. CAT scans, as we mentioned, are good at looking at bones. It's quite possible that the CAT scan could be completely normal for that patient and their age group, meaning no fractures, lots of arthritis, but nothing out of the ordinary. That doesn't necessarily mean they don't have a central cord syndrome. So if the history is pretty good for central cord syndrome and the physical exam is pretty good for central cord syndrome and the CAT scan really doesn't show much, the patient's going to get an MRI next. Now the MRI is going to be really good at looking at the spinal cord, and if the spinal cord on the MRI looks swollen, or as I showed you in the previous pictures, has that bright white signal or image inside the center of the spinal cord in the area where there's some pinching going on, combined with the clinical presentation, you're going to get a diagnosis of central cord syndrome. So keep in mind that that MRI that shows that bruising in the spinal cord, if that's repeated in a few days, don't be surprised if that bruising looks worse. That doesn't necessarily mean that ongoing injury is occurring. That white color inside the spinal cord is basically edema or swelling, and that can spread up and down the spinal cord with time without progressive or further injury. So don't be fooled or worried that just because the bruising looks worse means that bruising is continuing to occur. The other thing to kind of connect the dots for you is that the reason a trauma to the spinal cord can cause bruising in these areas is because that area of the spinal cord is called a watershed zone, which means that it's kind of where two areas of blood supply kind of meet and is not as strong as the more origin areas of that blood supply. So any injury to that watershed area can make the spinal cord more subject to bruising and spreading of that swelling in those watershed areas. So that area of central cord syndrome is a watershed area, and that's why it's more susceptible to trauma in the center part of the spinal cord. Another thing to keep in mind is that the ultimate degree of bruising or swelling in the spinal cord, as well as the presence of bleeding in the spinal cord, are all associated with prognosis. So the more bleeding, the more swelling, the larger the extent of swelling is going to lower the chances of strong improvement versus weak improvement. Most all of these patients improve, but the full extent of improvement varies. So now we've talked about the symptoms of central cord syndrome. Let's now talk about the treatment. Something to keep in mind with treatment of central cord syndrome is the fact that treatment is a very nuanced thing. There are lots of competing factors that can drive the team that you're dealing with to treat one way versus the other. In addition, the methods of treatment are controversial and have changed over time. In the old days, everybody with a spinal cord injury got steroids. Then some studies came out which demonstrated that steroids could actually make things worse in the long run. So most treatment teams are not going to use steroids. There are some small studies out there that did suggest that if you treat with steroids in the first 8 hours of the injury, there could be some improvement, but that was not a very strong study. So just keep in mind that the patient getting steroids or not getting steroids is going to be up to lots of factors that your treatment team is going to keep in mind or factor in. I personally tend to not give steroids in these situations. As far as whether to perform surgery or not, that can often be affected by factors such as how bad is the injury to begin with. Are there fractured pieces of bones that are pressing on the spinal cord? Is the spine unstable, meaning that there's ligamentous or bony injury that makes the spine not sturdy, and that if the patient is allowed to move their neck without a collar on, they could injure the spinal cord more because the spine is not stable. If there is instability or fractures, that will much more likely lead to the possible decision to have surgery. But the consensus out there is in the typical central cord syndrome patient, an older patient with arthritis that hit their head and has bruising of the spinal cord with no evidence of fracture or instability, the consensus is usually to avoid surgery. Surgery won't help, or it could make things worse. Usually these patients will be treated with conservative options. These conservative options include immobilization of the neck. That usually involves a cervical collar. Usually in the beginning it'll be a hard collar, which is pretty rigid, and then eventually change to a soft collar, which of course is softer. This is to prevent the patient from moving their neck around while the spinal cord is swollen, which could lead to more injury. If the patient has a spinal cord injury that's bad enough to have effects on blood pressure or problems with the bladder or bowels, or they have a lot of medical comorbidities or other problems, it's quite possible the patient will be watched in an intensive care unit for the first few days. If they're not able to walk, conservative therapies will include things to prevent complications of not being able to walk. Blood clots in the legs, pressure ulcers on the legs or buttocks from lying in bed too long, making sure they take deep breaths so they don't get pneumonias because they're not moving around a lot. Bladder management with catheters, physical therapy, occupational therapy to get the patient out of bed, breathing better, circulating their blood better, using their muscles early. These are all important factors in conservative management, the goal of which is to, number one, protect the spinal cord from further injury, prevent medical complications, and allow the body to heal naturally on its own from all the inflammation and swelling that's occurred from the initial injury. So when would someone like me get involved in a case like this? When would surgery be indicated? Well, that is typically going to be indicated when there's significant ongoing compression of the spinal cord. This is typically in the setting of a piece of a fractured bone pushing on the spinal cord. When the patient is not showing expected recovery, which you'd expect from a central cord syndrome injury, or when the spine is unstable, which I mentioned earlier, when it's basically wiggling around too much, and if the patient were allowed to move their neck around, it could pinch the spinal cord further. Again, there's a lot of controversy regarding whether to do surgery or not at all, and also if you're going to do surgery, when to do surgery. For me personally, as the neurosurgeon, for these typical patients that don't have fractures or instability, that are older and just have a buildup of arthritis and hit their head and hyperextended their neck and injured their spinal cord, I will typically not consider surgery for 2 or 3 weeks after the injury. I want to let the swelling around the spinal cord subside. I want to really get a picture to see if the patient's improving or not. And at that point, if I'm going to do surgery, it's primarily to prevent the patient from getting worse. I will often not guarantee the family or the patient that they're going to get better. I'm usually going to be considering an anterior or approach from the front of the neck versus a posterior or approach from the back of the neck. I usually am doing anterior approaches because in most of these patients, the pathology or abnormality that caused the impact on the spinal cord is coming from the front of the spinal cord. So therefore, I would want to come from the front of the spinal cord because I can get to all the problems before the spinal cord. I don't have to move the spinal cord around or manipulate the spinal cord very much in order to get out that pathology. So in the front approach, the surgeon will usually make an incision in the front of the neck here. They'll go down to the bones of the spinal canal and they'll either remove just the discs in between the bones and remove the bone spurs that are growing along the edges of the bones where the disc kind of meets the bone, or they'll remove the bone itself and the discs, and that's called a corpectomy, which is a bigger surgery. Usually you don't have to do that for these typical central cord syndrome patients, and the patient will get what's usually called an ACDF, anterior cervical discectomy and fusion. If you want to know about that surgery in much more detail, go visit some of my other videos about problems with the cervical spine on my channel, and I'll go into much more detail about that surgery. So if the surgeon tells you or your family member that you need an ACDF, take a look at that other video for details about that surgery. After the pinched parts are unpinched, the surgeon will typically fuse the bones together. That's usually with a titanium plate and screws along the bones to eventually get those bones to not move anymore. And that's the approach from the front. If the approach is going to be done from the back of the spine, that's typically called a laminectomy or a laminoplasty, that's where the lamina is either totally removed and made to disappear, or the lamina is cut on one side, hinged on the other, and then opened up to allow the spinal canal to be bigger. But when it's opened up, a little bone plug is put in the cut edge of the lamina cut in order to make that space bigger. Laminoplasty is not really done as much in the U.S. as outside the U.S. countries, but I may do a video on laminoplasty later, but you can always look that up if that's something your surgeon is going to suggest. An approach from the back with a laminectomy is typically done in patients that have multiple levels of compression. In that case, it's a much smaller surgery, safer surgery, easier surgery to do a laminectomy and open the spinal canal from the back, which indirectly unpinches it from the front by making the spinal canal bigger. and that's the laminectomy backside approach for surgery for central cord syndrome. As I mentioned earlier, when should surgery happen? A lot of controversy in that. If the patient has fractures, bleeding, or instability, the surgery should be early, within the first 24 to 48 hours. If the patient has the usual classic central cord syndrome picture, which I mentioned earlier, typically that can wait 2 to 3 weeks, again, to let the swelling go down and the patient kind of recover from the initial trauma. Regardless of the timing, regardless of the type of the surgery, all of these surgeries are meant to decompress the spinal cord. That's the ultimate goal. So now we've talked about treatment. Let's talk a little bit more about what to expect with recovery. What does recovery actually look like, and what can you realistically expect? Well, first, the good news is. The good news is that central cord syndrome has the best prognosis of all incomplete spinal cord injuries. The majority of patients recover meaningful function, and many walk independently and can use their hands. The timeline for spinal cord injury is usually a predictable pattern, and again, will occur individually. In the first days to weeks, if there's spinal shock, which means blood pressure problems, bowel, bladder problems, that can usually resolve. As it resolves, function begins to return. In the first 1 to 3 months, patients typically experience their most rapid and significant recovery. Most patients will typically be walking in those first 3 months. And then over the next 3 months, which are the first 6 months of recovery, you can expect more significant timelines of recovery in the arms and hands. And what I usually tell the typical central cord syndrome patient is that 1 year after the surgery, you can kind of look in the mirror, and that's probably what you're stuck with. And if you're going to be stuck with something, it's going to be that fine finger dexterity, motion capability, buttoning buttons, using utensils, those kinds of things that you may be left with some lasting deficit. So let's say you haven't reached 12 months yet and you're in the hospital still from the original injury and you found this video. What are some factors that are going to associate you with a better recovery in central cord syndrome? Well, those factors include age. So the younger you are, the better chance you have a recovery. The less severe the initial injury, the better chance you have for recovery. You may hear something called an ASIA score, ASIA score, A through E. The worse your ASIA score is, which is determined by the initial neurological deficit that you have, the worse your recovery is going to be, or the less chance you'll have for full recovery. The smaller and shorter the area of bright signal on your spinal cord and the lack of hemorrhage, the better chance you're going to have for recovery. The earlier and more aggressive you are with physical therapy and rehabilitation, the better your chances of recovery. The absence or lack of other medical problems, the better chance you'll have a recovery. And then if you have significant compression of the spinal cord or instability, the earlier the surgery to fix that, the better your recovery is going to be. Rehabilitation is not something that happens to you. It's something that you participate with. So in the beginning stages of your recovery, it's really important not to be unenthusiastic about your potential. You have to really think that you've got the greatest potential for recovery and really participate in that physical therapy and rehabilitation. So we've covered a lot of information today, but before we close, I want to just take a moment to address one further aspect of this problem, central cord syndrome, that's often not paid enough attention to, and that is the emotional and psychological stress or injury that this puts on the patient as well as caregivers and family members. The shock of this injury and the fear of what could happen puts a lot of weight and stress on the patient and their family. So it's really important that you take advantage of support through social workers, psychologists, psychiatrists, etc., as well as any of the resources I'll put down in links in my description for this video. So don't forget to pay attention to that aspect of this problem. It's very, very important for recovery. And the last point I want to emphasize is that central cord syndrome is an incomplete spinal cord injury syndrome, and the important thing to remember about this is how much you have potential for recovery. your attention to that recovery process is going to have a huge effect on your ultimate outcome, so don't forget to pay attention to that. So I hope this video was helpful. I hope it explained things in layman's terms. I hope it helps you get through this difficult time. Please subscribe and like to my channel. Take a look at some of my other videos on brain and spine disorders. And the most important thing, don't forget, stay healthy.